My name is Virender, and so you guys know me. So today I'll be doing my talk on glomerular diseases in pregnancy with focus as well as on general. We look at some data for chronic kidney disease. So basically, I had an interesting case while I was on the inpatient service, which sort of inspired me to do this topic. And as we all know, pregnancy itself is a challenging clinical situation because we have essentially two patients, as mother and fetus, and specifically glomerular diseases in pregnancy is difficult because of the fact that we have renal biopsy is not as easily attainable as in other cases, and as well as there's toxicity associated with immunosuppression. So all of our decision making is a little bit different in a pregnant patient as opposed to a non-pregnant individual. So the So the objectives of this talk today, I'll be, as I mentioned, illustrating the relationship between chronic kidney disease and pregnancy. We'll go over most of the talk is really preconception counseling, right? This is kind of the things you want to talk about your patient with in terms of outcomes prior to pursuing pregnancy. And then we're going to discuss some specific glomerular diseases in pregnant patients. In terms of an outline, I'll start off with some history. We'll go over some normal renal physiology of pregnancy and why it makes assessment of kidney function difficult. We'll talk a little bit about CKD and pregnancy, and then preconception counseling, some general management considerations, and then we'll look at some data for SLE, IgA nephropathy, ANCA-associated vasculitis, membranous nephropathy, and FSGS. So, by way of introduction, the first sort of time that we find pregnancy and kidney disease being linked in the literature is way back between 1839 and 1841 by this Dr. Pierre Francois Ray, a French physician. Interestingly, he's actually a dermatologist and pathologist, and nephrology didn't come around until like 100 years after this. So he was the first one to provide evidence of renal involvement in pregnancy by observing protein in the urine of pregnant age-matched women. By 1843, Lever, who was a British physician, he was a general practitioner with a special interest in obstetrics, reported that proteinuria and eclampsia had disappeared after delivery. In 1905, this was one of sort of like the landmark papers, which is called the albuminuria of pregnancy and kidney of pregnancy. It examined 5 cases differentiating between acute nephritis, chronic nephritis, and the kidney of pregnancy. The kidney of pregnancy that referred to in this paper is what we commonly today refer to as preeclampsia. By 1930s, there were specific risks identified with chronic kidney disease and pregnancy. And in 1963, there was this 10-year survey in Australia, which looked at the outcomes of 150 pregnancies in women with chronic kidney disease. In 1971, there was the first successful full-term pregnancy on a patient in a patient with who's on hemodialysis. So this I found was a kind of good quote to set the stage that, this was in 1975, children of women with renal disease used to be born dangerously or not at all if their doctors had their way. Obstetricians and physicians must batten down the hatches and prepare to ride out the storm together with those determined to set sail. So to introduce, glomerular diseases, the approach toward pregnancy overall has changed because of improvements in perinatal care, with more patients now kind of being open to pursuing pregnancy. There's not a lot of robust data with regards to glomerular diseases in pregnancy, again, linked to the fact that a lot of physicians aren't keen on pursuing kidney biopsy in these patients. And in terms of general population data, 3 to 6% of women of childbearing age have chronic kidney disease, and the most common glomerular diseases diagnosed by kidney biopsy would be FSGS, IgA nephropathy, and lupus nephritis. So, first of all, the limitations of kind of interpreting data with regards to pregnancy. Almost all of the data is referencing limited cohorts and single center studies. All of it is observational data. The studies that deal with CKD, the definitions are still heterogeneous, so we'll get into that a little bit. And then some of them use CKD severity based on creatinine. Some of them are EGFR based. There's misclassification if a pre-pregnancy creatinine is unavailable. This is an important point, which when we're talking about the sort of the physiological changes, it will sort of make sense a little bit more. And then there's a difficulty with even using a serum creatinine because none of the common equations that we use were designed for use in pregnant patients. So to briefly kind of go over the normal adaptive changes during pregnancy. So there are structural changes where you have an increase in kidney size. You have dilation of the collecting system more prominent on the right. That's because of the uterus changes and the some compression on the right side, as well as hormonal changes. In terms specifically for hormonal changes, you have a 10 to 20 times increase in aldosterone. You have an increase in renin, angiotensin. The most relevant to this presentation are the renal hemodynamic changes, which is the increase in GFR and renal plasma flow rate by 50% above normal. And this results in a decrease in BUN and serum creatinine. So this is sort of illustrated in this paper from 1983, which you can see here we have weeks of pregnancy and percent change, and you see GFR, this green line, goes up by around 50%. You have this decrease in your urea and your creatinine, which are all relevant. So this is sort of same similar thing with more recent. So this explains sort of the explanation for this, and it's glomerular hyperfiltration. So essentially, refers to the top graph here is a change in renal plasma flow. This graph is a change in GFR. So you see that in early in gestation, you have an increase in renal plasma flow, you have an increase in your GFR. The reason for this is the single nephron GFR here for different time courses during the pregnancy. Initially, you have a decrease in your afferent and efferent arteriolar resistance. The reason for that is to do with basically the hormonal changes of pregnancy. There's a hormone called relaxin that is produced. Later on in pregnancy, you also have an increase in the actual permeability of the glomerulus, and then it gradually returns to the pre-pregnancy states by 6 to 8 weeks postpartum. So, in terms of what does this mean for assessment of kidney function? So, as I mentioned earlier, the commonly used equations that we use, CK, FA, etc., they weren't evaluated in pregnant patients. Your serum creatinine decreases by approximately 20-25% below non-pregnant values, and a 24-hour creatinine clearance is considered the gold standard. But even in the data I looked at, even places didn't do this 24-hour creatinine clearance. And I think if you had a clinical situation, maybe you would do it, but at least not for the purposes of the data interpretation. That this was done. In terms of the serum creatinine decreasing, the reasons it's relevant is because if the only creatinine you had in terms of enrolling patients or looking at patients in the data, if it was in, for example, first trimester, it would be lower, and then when you check it again, in terms of checking your outcomes, it would appear to be associated with a negative outcome when really it was just going back to what it was before pregnancy. Right? So this was a population-based study out of Ontario, Canada, where they looked at, I think it was over 1 million pregnancies initially, and they tried to plot out basically these are low-risk pregnancies, trying to look at the serum creatinine. So this was women aged 16 to 50 years, and they had singleton live births. It was between 2006 and 2015. And so this top graph is the averages, and then what they tried to do was come up with a 95th percentile, 75th percentile, and 50th percentile to try and establish what is essentially a normal creatinine for pregnancy. So they found that the average was 0.7, declining 0.68, declining by 4 weeks to a low of 0.53, and then between 16 and 32 weeks gestation, it was at its lowest, and then it would rise to 0.72 a few weeks postpartum. And they found that in mid-trimester, creatinine of 0.7 to 0.8 to be their 95th percentile cutoff, and above this, we should be concerned. So this was a different paper. This was a systematic review. They looked at a lot of pregnancies as well, and it's trying to do the same thing, but they gave us a little bit more information on specific cutoffs, and they came up with a first trimester cutoff of 0.86. This is based on, again, a 95th percentile cutoff. A second trimester creatinine of 0.81, a third trimester creatinine of 0.87. So this was basically to say that if you have your patient in front of you and your creatinine is higher than this is probably something we should be concerned about. Now, just to make matters a little bit more murky, the American College of Obstetrics and Gynecology, they define their renal insufficiency severity, mild, moderate, and severe based on creatinine values. So some of the old data and data in the obstetric in the OBGYN field, they will use these instead of GFR as to classify their patients.
Do you prefer questions now or later?
It's fine. You could ask now. Yeah, sure.
I'm not sure if you're going to show later, but is there any data on cystatin C in pregnancy?
Yeah, so cystatin C was looked at, but cystatin C is actually the opposite to creatinine where it goes up during pregnancy, and the thought process is that it's produced by the placenta. So I don't think it's in use, or it's recommended right now.
Have they looked at data like what percentage goes up, or how is it discrepant? Or
I just looked at the bottom line, but I'm sure somebody looked at it. But
that's okay.
Yeah, but I don't have the big figures. So in terms of proteinuria, now they also looked at what's considered to be normal proteinuria, because we all know that based on the same concept of glomerular hyperfiltration, that proteinuria could will increase in pregnancy. Now, this is relevant to again our talk on glomerular diseases because you want to know what relevant increase in proteinuria is. So the traditional value is 300 milligrams in 24 hours, and that's kind of also falls into the definition of preeclampsia, right? So that's where you kind of like red flags. This was a more recent study from 2024, which looked at 5,379 women between January and July 23. And they tried to estimate, these were all normal pregnancies as well. It's considered low risk, uncomplicated. And they were trying to figure out, okay, what are the kind of thresholds we should be worried about? So their first trimester median was 72 milligrams and 95th percentile was 165. By second trimester, the median was 88 and 95th percentile 185 milligrams. And third trimester, median of 108 milligrams and 95th percentile of 258. So their kind of, their conclusion was that, hey, maybe 300 milligrams is a little bit high. Maybe we should be concerned a little bit lower than that. But that was, to kind of talk about the overall spectrum of kidney disease. These are like all the different things which we won't be really talking about all of these. So you have your hypertensive disorders of pregnancy, which I think usually takes front and center for preeclampsia. There's acute kidney injury, you can have microangiopathic syndromes, there's diabetic kidney disease, glomerular diseases, ADPKD, and chronic kidney disease. And for the purposes of this talk, I'll be sort of focusing a little bit on chronic kidney disease and then glomerular diseases. So chronic kidney disease and pregnancy, some of the data, this is one of the sort of larger cohorts. This was done back between it was looked at 2 Italian cohorts between 2000 and 2013. They compared pregnancy outcomes, 504 pregnancies in women with chronic kidney disease to 836 low-risk pregnancies. They looked at, they assessed the presence of hypertension, proteinuria, systemic disease, and CKD stage at baseline. So their outcomes were, the outcomes are generally similar in all studies. So you look at maternal outcomes and fetal outcomes. So cesarean section, preterm delivery, early preterm delivery, small for gestational age, need for neonatal ICU, the new onset hypertension, and new onset or doubling of proteinuria, and a CKD stage shift. They also looked at these combined outcomes. So their general combined outcome was preterm delivery, need for neonatal ICU, and small for gestational age. And their severe combined outcome was early preterm delivery, need for neonatal ICU, and small for gestational age. So early preterm delivery is less than 34 weeks, preterm delivery less than 37 weeks. So this study, just to look at kind of the characteristics of the patients, most of these patients were mild, so CKD stage 1 or 2, and only 16% of them were glomerular diseases. So this is very much, general chronic kidney disease patients. Now, they found that as your chronic kidney disease progresses, as you go from stage 1 to 2 to 3 to 4 and 5, that you have an increase in cesarean sections, you have an earlier, their babies are born earlier, gestational week goes down, preterm delivery goes up, you have increase in early preterm delivery, you have smaller babies because birth weight is down. So basically they found that in terms of all the outcomes, that they're worse as your kidney disease gets worse. Of course, the caveat is that they only had 10 patients with CKD 4 and 5, which is sort of a flaw of a lot of these studies. The thought process behind that is that those patients are generally discouraged from becoming pregnant in the first place, so they don't make it into the the data. So the interesting thing about this paper was that this was published in 2015, was that they basically suggested that chronic kidney disease stage 1 patients with preserved kidney function were still at a risk of negative outcomes. So they compared their CKD stage 1 patients versus low risk pregnancies. So they have all cases. Then it said if they didn't have any systemic disease, they said if they didn't have no systemic disease and protein and no proteinuria and no hypertension, and their first visit was less than 20 weeks. And they found they seem to suggest that, you know, regardless of if you have basically a GFR of 90, but you have some sort of kidney damage as by ADIGO guidelines, that you were still at risk for adverse pregnancy outcomes. So this was a follow-up paper in 2023, which sort of, I think, more or less informs what we know today, that that's not the case, where they showed that, you know, between a GFR of 90 and 60 to 90, so if you want to say mild CKD, that there was actually no difference in outcomes for them. What came out of this paper as well, interestingly, is they found that, okay, proteinuria seems to modulate negative outcomes. So they found that for each GFR category, higher proteinuria was associated with, they said, so that first graph with at least one severe maternal morbidity indicator. Maternal morbidity indicator in this paper was, I think there were like 44 maternal morbidity indicators, which range from things like pulmonary edema, acute kidney injury requiring dialysis, and all of the usual markers. And then preterm birth, less than 37 weeks, and low birth weight. So all of them, they severe, as your proteinuria gets worse, you're at higher risk. So to sort of conclude about the conclusions that we have about chronic kidney disease and pregnancy is that your degree of CKD determines your risk of maternal and fetal outcomes. Women with normal kidney function or mild CKD generally do not show worse kidney function in the absence of significant hypertension or proteinuria. I didn't show the data for the hypertension part of it, but you might have to take my word for it. Women with more advanced CKD are at risk for loss of kidney function, and then the three major determinants of outcomes are pre-pregnancy GFR, proteinuria, and hypertension. So now I'd like to get a little bit more into the glomerular disease part of it. So compared to other causes of chronic kidney disease, your outcomes are worse in patients that have glomerular disease, right? Excluding kidney function, and we'll get into that a little bit later. So how would you approach preconception counseling? So first of all, we won't be covering sort of all of these, but we'll cover some of them. So you want to address fertility, right? Effective glomerular disease and effective medications. Contraception, you want to focus on intrauterine devices are preferred. Second to those, progesterone contraceptive pills or progesterone implants. Estrogen-containing pills are less favored. You want to determine the optimum timing of pregnancy. You want to talk about how we're going to manage patients' hypertension, and then immunosuppression strategies, what's safe, what's not, and explain the risk of kidney disease progression and explain maternal fetal outcomes. So that's kind of what I'll be getting into later in the talk. So what about optimal timing? So the patients who are sort of like the ideal candidates for pregnancy. You want the glomerular disease to be stable for at least 6 months. Stable GFR. You want to have them having at least proteinuria less than 300 milligrams per day, well-controlled blood pressure, minimal infection risk, and stable doses of pregnancy safety immunosuppression. This is basically extrapolated from data on SLE and IgA nephropathy, which are the most robust data in pregnancy exists for those two conditions. This is the main thing I want to focus here on is in terms of pre-pregnancy counseling. You'd like to sort of put your patients into a category. Are they low risk, medium risk, or high added risk? So in terms of low risk, that's going to be your patients who are in remission and on no immunosuppression. In terms of medium risk, your remission is less than 12 to 18 months, but they are currently on immunosuppression. And of course, your active nephrotic syndrome and deteriorating renal function, remission less than 6 months are going to be your high risk patients who you're going to say maybe not a good idea to pursue pregnancy at that time. Now, what about the elephant in the room, right? Preeclampsia. So this was a nice diagram I found, which says that basically your placenta and kidney are sort of interconnected. So the placenta and kidney are highly vascularized. Both of them filter blood, divide compartments, and are sophisticated metabolic machines. And that pregnancy might be a precious occasion to diagnose chronic kidney disease. Basically, CKD can induce placental dysfunction, and as well as preeclampsia can lead to permanent kidney damage because, as we all know, there's a risk of chronic kidney disease later on in life after having preeclampsia during pregnancy. So how would we differentiate a patient with preeclampsia versus someone with renal disease? It's always challenging because they can present similarly, predominantly with an increase in proteinuria. So this is some of the things you look at. In preeclampsia, usually there's more of an abrupt worsening of proteinuria to the nephrotic range and severe elevation in blood pressure. The severe elevation in blood pressure part of it is probably less likely in a new onset glomerular disease. Can have blood pressure elevation, but it's less likely to be as severe as a preeclampsia. Preeclampsia, as we know as well, is associated with these premonitory symptoms. You have visual disturbances, headache, epigastric pain, and hyperreflexia. You also can have microangiopathic intravascular hemolysis, so the HELP syndrome. You can have a high uric acid in preeclampsia. And then you have these markers, which is the SFLT1 to platelet group PIGF ratio. Now, as far as I could tell, that's not in common clinical use, but again, I don't have as much experience with preeclampsia. But if that ratio is elevated, then that's more likely to be preeclampsia. I think there's some drawbacks with it in chronic kidney disease as well, but at least in normal pregnancies, they tend to use it. Also, for preeclampsia, you tend to have impaired placental blood flows, whereas that's something you shouldn't really see in glomerular disease. And preeclampsia, of course, should resolve post-pregnancy, whereas glomerular disease will persist. So hypertension in pregnancy, the goal blood pressure is controversial. Nephrology papers tend to say 130/80. The obstetricians, their guidelines have 140 or 90. I couldn't really find a consensus between the two. Agents of choice are labetalol, nifedipine, hydralazine, and methyl-dopa. Of course, we want to avoid ACE inhibitors and direct renin inhibitors, although there's some evidence that, not evidence, but there's some patient practice that people would continue them until the point of conception. Because, for example, in diabetic kidney disease with a lot of proteinuria, there may be some benefit to continuing it. And then the other thing is a lot of these patients with decreased fertility, there's no guarantee that they're going to become pregnant at any time soon. So you can actually continue them and just do like frequent pregnancy tests. That's one kind of approach. And then thiazide diuretics, they've not been associated with teratogenicity, but there is a theoretical risk of qualification. In terms of immunosuppression, what's safe, what's not. Steroids are traditionally being considered some of the safest agents to use. That being said, in the past, there was this possible association with cleft lip or palate, but in recent data that hasn't been supported. There's minimal placental transfer, so that's also not something that we have to be too concerned about. And of course, with a lot of them, gestational hypertension or diabetes is a concern. Azathioprine is safe if your doses are less than 2 milligrams per kilogram per day. Tacrolimus, also safe, but you have an increased risk of maternal gestational diabetes, neonatal kidney dysfunction, and hyperkalemia. And cyclosporin, also safe, but considered associated with maternal hypertension and gestational diabetes. The ones that are obviously contraindicated is going to be your mycophenolate and cyclophosphamide. Although that being said, cyclophosphamide has been used in some papers for as a form of rescue therapy in the third trimester. Limited evidence for rituximab. It's found to cross the placenta, it's detected in a newborn, and there have been some cases of neonatal B-cell depletion for up to 6 months post delivery. It's also recommended that you avoid live vaccines, obviously. So it's often used again as rescue therapy in the third trimester. Voclosporin, it's not really been looked at, but I think the packaging actually says avoiding pregnancy because the formulation contains alcohol. And then belimumab, again, not really used. I think they're just case reports, but it's a similar risk with rituximab where it is risk of neonatal B-cell depletion. So I tried to find some more information on this. It's controversial whether there's an increased risk of flare of pregnancy of glomerular diseases. And the papers that study yes, this is kind of some of the factors which they think it's kind of goes back to this glomerular hyperfiltration, where hemodynamic factors, you have immune system alterations, androgenic imbalance, and hormonal conditioning. But again, the jury is out whether there's actually an increased risk of glomerular disease flare, or if it's due to, meaning caused by pregnancy itself, or whether it's just due to poor disease control prior to conception. So how about a kidney biopsy? So this one also controversial. There's increased risk of complications and bleeding, as there's been estimated as high as 7%, compared to 1% after delivery. And the bleeding risk seems to be related to the increased renal blood flow, and it's usually, they say, wait at least like about 3 months post delivery to do the kidney biopsy. The other thing here is that timing is crucial. So there's no like guideline saying, it's safe to do a kidney biopsy at this time. The recommendation is that earlier in pregnancy, your benefit of being able to diagnose glomerular disease and have some sort of therapeutic impact is higher, so it's probably more beneficial. But as pregnancy progresses, that risk becomes higher with the pregnancy, and it's less likely that you're going to make some sort of change. And of course, delivery becomes also more of a possibility. So the cutoff I've seen is some places say like 24 weeks, they're more comfortable before 24 weeks. This particular reference said that like the 30-week mark, I think this is probably the most aggressive I've seen, and generally it's somewhere between 24 to 28 weeks, and beyond that, people are hesitant to pursue a kidney biopsy. So this is sort of a look at if you have a renal abnormality discovered during pregnancy. So it's a person who has not a known history of glomerular disease. The first part of it, isolated microscopic hematuria, it's worthwhile to know that this is actually could be normal, so it's not really usually pursued, but a lot of the times it's going to be someone with proteinuria. So you want to do this. The workup is pretty much similar to non-pregnant patients, your anti-PLA2R, ANE, anti-DSDNA, and complements. And then you do the urine protein creatinine ratio, urine albumin creatinine ratio is of course preferred, because a lot of times you're not going to get a 24-hour urine sample, but it's, in my case at least, we'll get it. I thought the 24 urine protein tends to be a little bit more accurate because of their decreased creatinine secretion. So in severe nephrotic syndrome, there's symptomatic treatment, which is kind of general for all patients. With sodium restriction, you can use diuretics, despite, as I mentioned earlier, that potential risk of volume depletion. And then thrombosis prevention, aspirin as well as low molecular weight heparin, usually if your albumin is less than 2.5. So in terms of this part here is, can you make a diagnosis, without doing a kidney biopsy? You can do a short trial of pregnancy compatible immunosuppression, which is going to be those options we talked about earlier, usually steroids as your first line. And if not, they recommend that you can do a kidney biopsy if its results with modified patient management. This particular reference also used 30 weeks as sort of their cutoff. So to get a little bit into now the specific glomerular diseases and look at the data. So as I mentioned earlier, lupus, you have the most robust data. So one of the big studies from 2010 looked at pregnancy outcomes in patients with lupus and SLE and lupus nephritis. This was 37 studies, 1,842 patients, and 2,751 pregnancies, so quite large. The maternal complications they looked at are maternal death, stroke, hypertension, preeclampsia, nephritis, and SLE flares. And fetal outcome was kind of unsuccessful pregnancy was their primary outcome, which included spontaneous abortion, stillbirth, neonatal deaths. They also looked at intrauterine growth restriction. So these are the rates of different complications, which has been kind of, in subsequent papers said, these are the numbers you can actually tell your patient. So there was a 5.9% rate of induced abortion, 16% rate of spontaneous abortions, 3.6% rate of stillbirths, 2.5% rate of neonatal deaths, and 23% rate of unsuccessful pregnancies, which on the flip side, that's 77% chance of successful pregnancy. So not too bad. And then intrauterine growth retardation, 12.7%, and a very high premature birth rate of 39%. In terms of maternal outcomes, the major ones here: hypertension, 16%, preeclampsia, 7.6%, and active nephritis, 16.1%, with the risk of flare estimated at 25.6%. So from this same paper, they also found, they looked at the association between active nephritis and history of nephritis. They found that it was significant for active nephritis, put you at increased risk of premature birth rate and hypertension, whereas even having a history of nephritis but not active at the time of conception put you at risk of hypertension and preeclampsia. So this was a different paper. This was sort of more well-controlled SLE patients. As we could see by the average creatinine was 0.7, proteinuria was only 0.4 grams, and they were on a low dose of prednisone, about 5 milligrams per day. And out of this paper, they looked at what were some of the predictors of preterm delivery, because as we just mentioned, there's a very high rate of preterm delivery in these SLE patients. Not surprisingly, the SLE activity, as documented by SLEDAI score, active nephritis, proteinuria, arterial hypertension, and previous renal flares, right, were all associated with this predictive preterm delivery. And in terms of their predictors of fetal loss, which again, only 6 cases, these were mainly to do with vascular disease and antiphospholipid antibody syndrome, as well as arterial hypertension. So this was just another paper. This was more recent, looking at general lupus. I kind of want to highlight here that patients, this was 10,000 pregnancies, so again, a large sample. Previous lupus nephritis was associated with increased live birth probability, increased risk of preterm birth, and increased risk of preeclampsia. The odds ratios are pretty much similar to what was documented prior. And then what are sort of like your risk factors for flare, or what might predict lupus nephritis flare during pregnancy? So this paper looked at that, and they found that low C4 and a history of kidney disease prior were associated with higher risk of flare. And the other thing that they found was that anti-dsDNA, which has traditionally been kind of considered a risk factor for flare lupus flare during pregnancy, was actually not associated with it. So they thought that this should probably not be a factor that we use to discourage our lupus patients from pregnancy. So management, as I mentioned earlier, you want remission for at least 6 months. You want to stop MMF. You want to put your immunosuppression of choice is going to be prednisone, azathioprine, and CNI. There's a lot of evidence out there that hydroxychloroquine is also protective. As I mentioned earlier, your ACE inhibitor can be continued until conception, and you want to screen for SSA, SSAB antibodies because of the risk of neonatal heart block, and then as well your antiphospholipid antibodies, which we just described is kind of negative prognostic marker. And during pregnancy, hypertension management, spoke about earlier, low dose aspirin, and then in cases with antiphospholipid antibody syndrome, you want to do VTE prophylaxis. So this is sort of like a summary of the management of lupus nephritis flare, which we sort of covered already. If your first line of a flare is going to be corticosteroids plus azathioprine. Second line, you can do CNI. They provide trough levels for tacrolimus and cyclosporin, and then third line is going to be rituximab if you don't have any appropriate alternative. So IgA nephropathy, which is the other sort of we have a lot of data for. It's the most common primary glomerular disease worldwide, and because its peak incidence is again young patients, second and third decades of life, that's sort of why we have a lot of data on pregnancy outcomes. So back in 1991, this was one of the early studies which suggested that in pregnant patients with IgA nephropathy versus non-pregnant patients, there was actually not a whole lot of difference in change in GFR. Both of them lost kidney function over 5 years, but there's not a whole lot of, there's not any difference between being pregnant or non-pregnant. So this sort of informed the general thought process that patients with IgA nephropathy really didn't experience a progression of their kidney disease with pregnancy. So this is a more recent paper. This looked at patients between 1966 and 2018. They looked at about 1,200 participants. Their renal outcomes was doubling of serum creatinine and 50% decline in GFR or end-stage kidney disease. And as you can see, they found an odds ratio of 0.9 between pregnancy and non-pregnancy. So it really wasn't significant. However, that being said, this was a paper which specifically they had more patients in CKD stages 3 and 4. And they did find that if you had advanced chronic kidney disease, you were at risk of having progression. And that's sort of also what informs our general thought process, which is that if your kidney function, if you have advanced stages of CKD at conception, that you're at higher risk for loss of kidney function. In terms of this is also a larger systematic review. This looked at patients between January and April of 2017. Now, this one, in terms of how they looked at progression of kidney disease, they compared them to non-pregnant IgA nephropathy patients, and then in order for them to look at their pregnancy outcomes, they compared them to non-IgA nephropathy pregnancies. So similar to before, they found no significant increased odds for progressing to end-stage kidney disease or needing renal replacement therapy in patients with IgA nephropathy versus not. And they did, however, find increased risk of preeclampsia, preterm delivery, pregnancy-induced hypertension, and low birth weight in patients with IgA nephropathy and pregnancy, and these were quite elevated odds ratios. So management overall for IgA nephropathy, you want to ideally stop any RAS inhibitors, SGLT2 inhibitors, sparsentan, nefecon, and systemic glucocorticoids. You want to optimize their blood pressure. And in women at risk of progressive kidney loss, so if they have active disease, essentially, you want to probably address that with trial treatments prior to conception. In terms of breastfeeding, neither SGLT2 inhibitors or sparsentan have been used. Enalapril can be used if you need to do renin-angiotensin system inhibitor. So this is where the evidence is less strong for the remaining ones. So ANCA-associated vasculitis, limited published literature. This is like just a case series where they looked at 137 pregnancies in 110 patients, and they found that basically it was just descriptive that, and most of these patients as well, the ones that they have data for, they were in remission for approximately 36 months. So these were pretty healthy patients. Treatment during pregnancy, the interesting thing here is that a lot of them got cyclophosphamide, which we mentioned earlier is not really recommended, but I think this was mostly these cases came from before 2005, I think, which is where why the cyclophosphamide was so high in those. They did have an increased rate of low birth weight and intrauterine growth restriction, as well as preterm delivery, in keeping with what we've seen with all glomerular diseases that we discussed so far. So membranous nephropathy, again, not a whole lot of data. There's 2 case series from the 1970s and 80s with poor maternal and fetal outcomes. More recent case series reflects better outcomes, management. Calcineurin inhibitors are going to be your first line, and then cyclophosphamide and rituximab preserved as rescue therapies. This was a paper which looked at primary membranous nephropathy in pregnancy. They found that they looked at 27 pregnancies. These were all biopsy-proven primary membranous nephropathy. They found a fetal loss rate of 11%, preterm delivery 26%, and severe preeclampsia 15%. They found that serum albumin less than 2.5 before 20 weeks of gestation, as well as increased proteinuria and PLA2R positivity were all associated or risk factors for negative outcomes. So FSGS and minimal change disease, even less data for these. It hasn't been established an incidence. The teaching is that in known FSGS and minimal change disease, the risk of relapse is likely higher in patients who are corticosteroid dependent, but this is extrapolated from non-pregnant patients. Treatment is going to be corticosteroids, calcineurin inhibitors, and rituximab or alternatives. This I really just wanted to illustrate kind of like how low these are all the patients between 2000 and I think 2023 in terms of case reports, and there's like 3, 16, and 8. So not a whole lot of cases. This is sort of like overview, we kind of talked about this already of your immunosuppressive treatment options. So minimal change disease, FSGS, corticosteroids, CNIs, and azathioprine inhibitor. Remember this nephropathy, your first line is going to be your CNI, IgA we spoke about, corticosteroids, CNI, azathioprine. I didn't include C3GN in this talk just because it was sort of so rare. And there's again similar problem with antivasculitis, not a whole lot of data for it. And then lupus nephritis, I kind of displayed that part of this already. So just to end my talk, I just wanted to sort of bring up the case that I had, which is sort of in progress. So this is a 37-year-old South Asian female. She was at 21 weeks, 6 days gestation when we were consulted. She had a history of rheumatoid arthritis, recurrent pregnancy loss, and she came in due to periorbital swelling, lower extremity swelling, as well as some shortness of breath. Now, for obstetric history, in May of 2016, she had a 5-month induced pregnancy termination in India due to proteinuria. We don't have obviously a lot of details about this. And a kidney biopsy done shortly after this termination showed FSGS. She was treated with a 10-month course of steroids and she's been in remission since. So now, all I had for this kidney biopsy was a picture on the husband's phone with like sort of like the bottom line being FSGS. So not a whole lot of more information there. She moved to the US, I think, in 2020, and then in January 2024 and July 24, she had pre-trimester miscarriages. In 2025, she had a history of IVF twice, both unsuccessful. So this pregnancy is a spontaneous pregnancy, and I think we can all agree it seems like a precious pregnancy for this patient. Medication-wise, she was just on hydroxychloroquine, which was started in June of last year when she saw rheumatology. Because at that time, again, she was pursuing pregnancy and they deemed that to be a safe agent for her to use for her rheumatoid arthritis. Blood pressure was 109/65. She was not hypertensive throughout the hospital admission, so our sort of suspicion for preeclampsia was very, very low. Her serum creatinine was 0.4 to 0.5 urinalysis planned. She had 11 grams proteinuria by a 24 urine collection and a protein creatinine ratio of 16. Her workup all negative and complements and were also normal. So we decided to manage her as a case of relapsed FSGS just based on her prior kidney biopsy. And she was started on prednisone 60 milligrams and discharged with clinic follow-up. So after 12 weeks, her urine protein creatinine ratio had increased to 17. So at 8 weeks, it was 13.3. So at week 12, tacrolimus was added, and 1 week later, it's 12.8. So sort of too soon to make any big pronouncements, but potentially some improvement. She's currently 34 weeks, 6 days gestation, and she has a planned induction date on 5th of April. So take-home points. Assessing renal function in pregnancy involves adjusted serum creatinine cutoffs due to physiological increase in GFR. The degree of chronic kidney disease is an important determinant of maternal and fetal outcomes with increased risk as your GFR declines. We have the most robust data for SLE and IgA nephropathy, and SLE, your woman with active disease should be discouraged from conceiving until that disease is controlled for more than 6 months. And a history of lupus nephritis prior, as well as low C4, have been associated with increased risk of, at conception, have been associated with an increased risk of lupus nephritis flare during pregnancy. IgA nephropathy, generally, there's a low risk of progression if you have preserved kidney function, but even with preserved kidney function, there's an increased risk of negative fetal outcomes, and there's limited data for ANCA-associated vasculitis, membranous nephropathy, and FSGS and minimal change disease. So, most importantly, preconception counseling and pregnancy planning are essential steps because, of course, patients with controlled disease, controlled blood pressure, and proteinuria have all been associated with improved maternal and fetal outcomes. That brings me to the end of my presentation.
That was great. This comment you made about the first part of your talk, you were talking about the general CKD and the frequency. So the data that you showed are mostly going well here. That's how they can but as we all know, GFR, the CKD is not defined only by GFR. We had a case 3-4 years ago here at the UF. A 39-year-old lady, actually happens to be a doctor, who wanted to become pregnant, and just previously they did some kind of ultrasound and they found that she has one kidney. So she's by definition CKD, and then proteinuria is 500 milligrams. So the question was, should I get pregnant or not?
Right.
We had a heated discussion here in one of the case conferences. There is a paper in AJK that says they have a higher rate of pregnancy loss and all the complications.
Right.
But some of the colleagues were arguing that there are lots of donors that they give them, because she's otherwise she's fairly normal, beyond and all those, that she should get pregnant.
Right.
And her question was, should I get pregnant or not? Right? Basically, yes or no.
Yeah.
So
I think, at least based on the most recent data presented there, it seemed like she should. But I mean, obviously, there's no correct answer. But just another thing, another point in what you mentioned, what was I gonna say? Yeah, it's difficult, but I think at least there's no right answer based on the data, because it's conflicting. That earlier study from 2015 said yes, that it is associated with negative outcomes. Second one said no. So I don't know.
I think this associated with negative outcome doesn't mean the negative outcomes are more likely to the positive outcome.
Okay.
Do you know what I mean? Like I've been sort of, as I've evolved in my career, because you also carrying a contrast with personal and like, yes, we're at greater risk than if you had normal kidney function, but overwhelmingly the likelihood is that you're not gonna have, right? And so, I mean, it requires some counseling, I think, but in a situation like this, I mean, I feel like, the odds are that you won't have a problem because you are at high risk.
And to Mona's point, she was 39. That's why I remember the age that she was getting close to the point that this is pretty much the end. At the same time, because she's a little bit on the older side of pregnancy, and sorry. Oh, let's say.
But sometimes the patient that you just reported is after 24 weeks. Spilling like 12 plus grams of protein. Why is her end of pregnancy planned for April? Like, what is the benefit of keeping the pregnancy beyond 36 weeks?
That's a good question. I think the BGYNs, that's their plan. They see her like every week. So I keep an eye on it.
They haven't seen program yet, probably.
That's a good
Guidelines that it's no benefit beyond 36 weeks in a high-risk pregnancy.
That's a good point, but where I don't know if they actually are as worried about it as I am, because when I spoke to them first,
I just haven't noticed it yet.
they were sort of like,
this
is going to take some time to get better. Let's just the shot, that kind of adds, like, wait, like, how many pregnancies have you actually seen like this in that kind of way? So they didn't seem to be overly concerned, and that was a little bit.
But I think that's my experience with COVID from our patient that we had with the IgA biopsy. They didn't want to keep the patient and the kidney function was getting worse on a daily basis. They didn't want to keep the patient fit. But we just had to have that conversation and say, no, patients.
I agree. As soon as I saw that 4-5 as a due date, and I'm like, what's going on? It's 34 weeks already. What are you doing here? Like, why 12 grams?
Consult me.
Having said that, and so as much as I agree with you on almost completely, because it was the exact same question I had, there is a little difference between an absolutely stone cold normal creatinine / GFR function with proteinuria versus a combination of declining GFR with proteinuria. To that end, especially, and I think your experience in this particular patient suggests with 17 grams of proteinuria for more than almost, 10 grams, 15 grams, whatever. But you have more than almost 14 weeks of this lady with you with 17 grams proteinuria. You have fairly stable patients.
Yeah.
And then on the other hand, you will see these non-nephrotic but reduced GFR, primarily the proliferative component, GN type of picture. And those are the ones that just go down very rapidly. And I think there is a little bit difference here between this particular cohort, but I completely agree now. This just looks like that. They're waiting for like, why can't we just have a complicated?
So question is, what gestation did you start tacrolimus on her? Age?
83 weeks.
33?
Yeah, 33. So it's basically a week ago.
Okay. Question is, how is the data on B cell depletion with rituximab in newborn? Like, have they? I understand the theoretical, you
Right.
can have B cell depletion. Compared to CNI,
Yeah.
rituximab outcomes in newborn. Do we have any data?
I think it's just case reports. So I didn't see anything more than a few case reports where it was used. These things I think most people don't want to use it in the first place because again, theoretical risk, and then it comes from this whole case reports of
Yeah, that's what I'm wondering.
but I don't have
how
any-
much is the data of CNI versus rituximab in pregnancy?
I don't have any idea.
I actually, sorry, you go ahead. Mine is very.
I might just be like derail a little bit in a different area. What I always find interesting is strong immunosuppressants in male patients, right? How does that affect the fetus if the family, if the family is planning on conception? Because there are some meds that are more benign, others with low outcomes. And it's something you may want to consult patients in. It's not just a women's problem. I just want to make sure you understand, right?
What can we say? She's at the point.
The only question that I had from tacrolimus is like, I completely see your point of starting it, but like, what you have done 12 weeks without tacrolimus and its vasoconstrictive effect and everything, whether this is drawing any benefit extra.
Maybe this is the question.
Thank you very much.
Thank you.
It's not on, it's at 40, you start reaching out. So before that, you just have a lot of advantage. You just reach our place at that point. That's not, it didn't mean that you